One. Please start, ma'am. We are live.
Namaskar and good evening, everyone. I welcome you all for today's webinar on new paradigms in the management of lung cancer. And with immense pleasure, I would like to invite Dr. Raghav Kesri, who is Consultant Medical Oncologist, Metro Hospital, Faridabad, for the welcome and introductory note and to set the ball rolling. Over to you, sir.
Good evening, everyone. I would like to welcome all of you on this in this virtual conference on new paradigms in the management of lung cancer. As you all know, lung cancer is an extremely extensive topic. So trying to cover it in 2 hours is actually a very difficult job, even if we are trying to cover only the latest updates. We will be covering on a lot of topics with the role of immunotherapy currently in the lung cancer. And with this, I would also like to thank Dr. Sumat Gupta and Dr. Shivam for giving me this opportunity to moderate the conference. So I think we can start the session now.
So, our first speaker of today is Dr. Kunal Sharma, who is Associate Director and Head Center of Excellence and Histopathology Mumbai Reference Lab SRL Diagnostic, and he's going to talk on biomarker-driven strategies in the management of NSCLC and overview. Over to you, sir.
So Kunal sir will be joining within 2 minutes now. So have some issue.
Okay.
Okay.
So,
Dr. Kunal will be joining us in 1 or 2 minutes. So I'm very thankful for everyone for joining us. And I know Raghav has been unwell today, and I'm very thankful for Dr. Raghav for taking up the center stage. Thank you, everyone from the team, organizing team, for being so supportive, all the faculty for joining in. Dr. Kunal has been having some issues with his internet, so he has taken up 1 or 2 minutes to join us. So please bear with us. Basically, we are on time and we hope that we'll be finishing on time today. Lung cancer, as we all know, is always a burning topic, and I think we'll have good debates. We'll have a good scientific session. I'm thankful to Ekta ma'am for hosting us, and I think we'll have some very nice sessions today. I think Kunal is trying to join us. Ekta ma'am?
so far, he's not there, sir. So can one of
He's not joined right now.
Okay, in 1 or 2 minutes, he will be joining, sir.
So let's just wait. I'll try to call him up. Yeah. He's just joining us in few seconds. There was an issue with his laptop.
I think Dr. Kunal Sharma is there with us now. Sir, is your connectivity fine? You can just hear us. Sir, you need to unmute yourself.
No, there was just some technical glitches.
Yeah.
So
Okay.
apologies
Oh.
for having, everyone to wait.
So no issue. And sir is going to speak today on biomarker-driven strategies in the management of NSCLC and overview. And Dr. Kunal Sharma is Associate Director and Head Center of Excellence and Histopathology, Mumbai Reference Lab, SRL Diagnostic. Over to you, sir, for your talk.
Is my screen visible?
So
Yes,
very
sir.
much. Very much.
All right. So, I would first like to wish everybody a happy Ganesh Chaturthi from Mumbai. It's a very, very big festival that is celebrated here. So, without much ado, because we've had some initial technical glitches, I would like to proceed with my talk on biomarker-driven strategies in the management of NSCLC and overview. As we know, lung cancer about more than 2 million cases and almost 1.8 million deaths per year are caused due to lung cancer. A very important thing which I would like to share with everyone is that lung cancer has almost stood out as a prototype of targeted treatments and biomarker driven management, in which we have moved from an era where we had a one size fits all approach of broad spectrum chemotherapeutic agents to agents which specifically target tumors which have particular specific underlying mutations. So these targeted therapies are directed against oncogenic driver mutations, which are unique to the cancer cells, and hence they spare the normal cells. Another important thing is that most but not all lung cancers are associated with a well-known carcinogen, that is tobacco smoking. In cases of squamous cell carcinoma, it is usually associated with smoking high tar content additives, whereas in adenocarcinoma, it is usually low to moderate tar content additives. It's important to know this because we usually go for biomarker testing in those in which we suspect oncogenic driver mutations, which are usually non-smokers or less smokers and younger patients. So whenever we are looking at anything, it's very important to understand the classification. As we know, lung cancer is divided into non-small cell and small cell. Non-small cell is further divided into squamous cell carcinoma, adenocarcinoma, and large cell carcinoma. The biomarker testing is most frequently prescribed for adenocarcinomas because they are the most well understood and they have potent targeted treatments available. In cases of squamous cell carcinomas, these are still early days, and mainly we look at these cases. Why is it important to note what is the histology? Is because most of your biomarker testing will depend upon the type of histology that we have. As I told you, adenocarcinomas are the ones which are most frequently prescribed for biomarker testing. Whenever we get a core CT guided lung biopsy, what we usually do is that we divide it upfront into two blocks, so that one block can proceed with histopathology and IC evaluation, and the other block can undergo the molecular testing. So, adenocarcinoma is divided into different morphological types. That is lepidic, acinar, papillary, micropapillary, and solid adenocarcinomas. Squamous cell carcinomas are also divided into different types, which are keratinizing squamous, non-keratinizing, which is low grade. Acinar and papillary are intermediate grade, and carcinomas, are the ones with poorer prognosis. Here you can see the keratinoid basaloid when the basaloid component is at least 50%. So with that, I would just like to proceed with the biomarker. In large cell neuroendocrine carcinomas, we don't have a lot of biomarkers. First came about at the advent of 21st century as anti-TKIs were tested on lung cancer patients. These were geftinib and erlotinib. Crizotinib was initially developed as a MET inhibitor, and further research contributed to identification of a whole new range of druggable targets, particularly for adenocarcinomas. As I told you, squamous cell carcinomas, we usually see the immune, we test for Pdl1. And these patients show spectacular improvement, particularly in those who lack TKI sensitive mutations. Now, in adenocarcinomas, till even today, most of the adenocarcinomas, about 40% of the cases globally, we don't see known mutations. But the picture slightly changes in the ones in which we see mutations. Like in the Western population, the kind of mutation patterns are different. more often we see KRAS mutations, whereas in the Asian subcontinent, we usually see the EGFR mutations, which are most prevalent. Squamous cell carcinomas, we do see a lot of mutations, but they are not targetable as of now. So KRAS mutations are associated with smokers. EGFR, ALK, ROS, and RET are usually seen in non-smokers. As I told you, in Asians, the percentage of EGFR mutations is high. If you are getting an EGFR mutation in a squamous cell carcinoma, the first thing you should consider is a histological misdiagnosis, or these would probably have elements of a mixed histology and the adeno component has been missed. The two major EGFR mutations we see are in-frame deletions of exon 19 and the L858 substitutions in exon 21, which are usually seen in the elderly. There are other rarer mutations like exon 18 nucleotide alterations, 19 in-frame insertions, 20 alterations, and 21 mutations. ALK and ROS1 translocations occur in about 5 to 8% and 1 to 2% of non-squamous NSCLCs respectively. Women and non-smokers, like EGFR, no racial differences. These are usually seen in younger patients. In contrast to the EGFR, there is a significant diversity of secondary mutations in ALK and ROS1. The probability of a particular TKI-resistant substitution may depend upon the type of translocation. For ALK testing, IHC is a positive cases must be validated by an alternative assay like FISH. Coming to BRAF. BRAF is the easiest to test as all druggable mutations fall on the same hotspot region. BRAF V600E, that exon 15. This is seen in 1 to 2% of adenocarcinomas. Single agent usually results in rapid resistance through MEK pathway. Therefore, a combined approach is usually instituted. Exon 11 mutations are detected rarely, but these are non-druggable. Then coming to the MET exon 14 skipping mutations, this results in overexpression of this receptor. This is seen in about 2 to 3% of non-squamous NSCLCs. And these are usually the elderly population who do not tolerate cytotoxic therapy well. Thus, if you are seeing a patient over 70 years of age, you should prioritize MET over ALK, ROS, and RET. The drugs used are crizotinib, capematinib, and teptotinib. Then the RET mutation seen in about 1 to 2 NSCLCs. One of the newer kids on the block is the NTRK gene fusions, which were identified first in 2013. And so there are 3 NTRKs, that is NTRK 1, 2, and 3. These are seen in about 0.2% of non-squamous, non-small cell lung cancers. The drugs that are used for these mutations are entrectinib and larotrectinib. There are a variety of options to be able to test NTRK. I mean, there is IHC, RNA, DNA, NGS, FISH, and RT-PCR. There are advantages and disadvantages with each of the modalities. While RNA NGS is the most sensitive, IHC will always offer us cheaper prices and faster TAT. But the cases, IHC is a very good screening modality. So what is negative, you don't need to test further. But whatever comes positive on IHC, you should definitely validate it with a higher modality like RNA NGS. So many a times, people ask me, which is the platform that we should use whenever we are going for these molecular targets. So see, if your sample has high volume, any method will work. But if your sample has low volume, you need amplification of the genetic material. So something like an ARMS would be the best modality. Whenever you have a mutation type which is known, like let's say EGFR, you can use a targeted method like PCR. But when your mutation type is unknown, then broad spectrum next generation sequencing is the studies that have been done. And for KRAS G12C, FDA approved the first targeted therapy. And these are patients with non-small cell lung cancer whose tumor have the KRAS G12C mutation and who have received at least one prior systemic therapy. The drug which FDA approved was sotorasib. Also, studies are coming forward for pyrotinib and HER2 mutant advanced lung adenocarcinoma. Then coming to Pdl1 mutations in lung cancers, there are different clones for Pdl1. There is the SP142, SP263, and DACO22C3. The clone we most often test is the DACO22C3 clone. And what we should usually do is, these are companion diagnostics. You should use the DACO clone on the DACO platform, and then these patients should be considered for pembrolizumab therapy. So the FDA approved, what we usually give is the TPS score in cases of lung, because inflammatory cells in lung are very few. So TPS correlates very well with CPS. And they saw that when you correlate with TPS, the understanding of the tumor was better. These are just the different types of staining that we see. What we should look for is a nice membranous staining. We should definitely avoid, when we are counting TPS, we should not count the inflammatory cells. Also, we should be careful of areas with necrosis because these usually stain positive for.
My apologies, sir. You are left with just 1 minute to conclude your presentation.
Sure. So
Thank
I
you.
don't have much remaining. I would just like to show in a nutshell, this chart, which beautifully shows what all mutations, what all biomarkers we can test, and what are the drugs available. EGFR mutations have osimertinib, erlotinib, afatinib, geftinib. Then we have the ALK positive cases wherein the ALK inhibitors are used. ROS1 and ALK show homology, so they use crizotinib, entrectinib. For BRAF, we use dabrafenib, entrectinib, and for EGFR T790M mutations, which are usually seen in relapse cases, we go for osimertinib. This is again the same chart. In SRL, we have a NSCLC panel which covers both DNA and RNA variations in all these genes. I would just like to quickly embark upon liquid biopsy. These are important and these are very, very handy, especially in late recurrent cases because they capture tumor heterogeneity. Even few copies of mutant ctDNA are sufficient for analysis. These are non-invasive and less expensive. And these are very compliant because in cases who have been treated, you might not get a repeat biopsy might not be very compliant from patient compliance perspective. So liquid biopsies can be used. At SRL, we have a SRL liquid biopsy EGFR true test, which targets 42 mutations in 4 exons, 18, 19, 20, and 21. These are the test details. But we must know, I would just like to conclude with limitations of ctDNA. We must know that these are not very, very handy in early stage of disease because patients might not have sufficient ctDNA. Also, presence of normal genomic DNA hinders with early stage disease and early detection. The sensitivity of ctDNA detections of mutations at these ultra sensitive levels require a very, a lot of detailed cross-validation across platforms and across laboratories. I would just like to finally conclude by saying that in India, we still have 2 spectrums. Most commonly, we get testing prescriptions for EGFR, ALK, and ROS1 because of cost implications. The others are just testing all the targets at one go. One point of caution would be that wait for your NGS reports before you institute your Pdl1 treatment because NGS report will take time, but Pdl1 report might be available to you for 2 days. So with that, I conclude my talk.
Thank you, sir. Thank you so much. Thank you for the wonderful presentation.
My team at SRL Bombay, and I thank the organizers for giving me this opportunity.
May I ask one question to Dr. Kunal? Sir, I want to know whether the all MAT exon 14 mutation are skipping mutation or not. Means how to look at that, because only skipping mutation are targetable, not other. So
yeah,
how
so
to
all the mutations are not skipping mutations. So there are very specific patterns that we evaluate for the skipping mutations. And as you rightly said, that only the skipping mutation should be considered. The other mutations, we see a lot of other variances and varieties of mutations which are there, but those should not be considered for considering a MET, for targeted treatment.
So you mentioned in your report that it is skipping mutation or not?
Yeah, so we analyze only for the skipping mutation. Even our NSCLC panel, we analyze only for the skipping mutations.
Thank you, sir. Thank you, sir. Thank you so much for your for enriching us with the biomarker-driven strategies.
My pleasure. Thank you so much.
And next, we move on to the upcoming session, which is sponsored by our academic partner, AstraZeneca. It is a case-based panel discussion on advanced EGFR, NSCLC. And to moderate the panel, I would like to invite Dr. Alok Gupta, who is Professor Medical Oncology, Tata Memorial Hospital, New Chandigarh and Sangrur, Punjab, to invite their panelists. Over to you, sir.
Hello. Yeah.
Yes.
At the outset, I would like to thank the organizers for giving me this opportunity. because we are short of time and only 20 minutes are given, I think all the panelists know each other and they are well known in their circle. So I will not introduce all of them one by one. Please invite all the panelists to be online so that we can have an academic discussion and we can enrich ourselves.
So I would request all the panelists to switch on their video to have an interactive discussion. So panelists on board are, I think, Dr. Mohit Saxena, Dr. Yogesh Nishchal, Dr. Abhishek, can you switch on the video, sir?
So if all the panelists are there, can we continue? So it's just an informal discussion which we will have.
Yes, sir. You can proceed with.
So in the next 15-20 minutes, we will like to embark upon using a case-based scenario to discuss the landscape of a rapidly changing treatment modality, which is in metastatic EGFR mutant non-small cell lung cancer. And there have been explosion of therapies in this disease subgroup. And with increase in these choices, we are left confused of how to use these therapies for the most benefit of the patient, how to sequence them, and how to use them. With the help of our esteemed panelists today, we will try to give an answer to some of these questions so that we can be wiser when we see such type of patient tomorrow in our clinic. Next slide, please. So a basic case history of what usually we see these type of patients in our OPD. A 54-year-old male, former smoker with a past 20-year history of smoking, type 2 diabetic mellitus, very fit patient, ECOG 0, was presented to the hospital in view of relative chest pain and shortness of breath over past few months. Next slide, please. So if we could see the CT test of this patient, there is a left lobe pulmonary mass and there is an adrenal met. So a histology, a biopsy was taken and it came out to be adenocarcinoma. So a diagnosis of a metastatic non-small cell lung cancer was made. Next slide, please. On further molecular analysis, the patient came out to be positive for EGFR mutation, which was present on exon 21 L858R mutation. So I will like to ask my panelists first, what percentage of your patient you see in your OPD with metastatic lung cancer are EGFR positive? So if I can start with Dr. Ashwin Phillips, is Dr. Ashwin on the panel?
So Dr. Ashwin is not there.
So Dr. Yogesh, if you could please start the panel. What percentage of your patient you see are EGFR mutant positive?
Thank you. Thank you. Can you hear me all right?
Yeah, you are audible, sir. You are audible. Sir.
Fine. I mean, we all know that these kind of patients, we get probably 10 to 15% out of the total lot. And if we look at the number, what you get through the clinic, I would say probably, I mean, if we count, you can count these patients on your fingers for the whole year. So in my practice, I would probably see 5 to 10 patients in the whole year, to be honest.
Okay. So the Indian data which is there, which we see from Tata and from AIMS, show that almost 25% of patients of what all metastatic EGFR, metastatic adenocarcinoma lung are EGFR positive. So does any of the panelists in their practice see that amount of number or percentage of EGFR positive in their practice?
No, sir. Probably it is low. I think we don't see more than 15 or maximum 20%. It is almost, I think, 15% or so. Probably because we see more of a smoker. That might be one reason, that we get less EGFR mutant positivity in comparison to the national data and the study published. That might be reason.
So do you think that referral bias to academic or academic institute might be the reason why some of these patients who are difficult to diagnose because they are non-smoker, females, young age, which are referred from physician to oncologist because they are missed, might be a reason that in a general practice we see lesser number of EGFR positive, and in an institute level we might see a higher number of patients who are EGFR mutant positive?
Quite probable,
from my panelists here.
Quite probable, sir, because in practice, clinical practice, it is different. And when we see the population-based study, then we will get the real data. And I think in the institute or in the bigger center, I think the number of the patients might be more. That might be reason that they get the true percentage. And there might be referral bias we get when we see at our clinical practice. But actually, that's for sure that the actual number which we see is less than the national data.
So if I share my experience, when I was in TMH Mumbai, I used to see a lot of patients who are EGFR positive, and that average might be 20-25%. But now when I'm working in Punjab, definitely maybe due to whatever reason I couldn't, the percentage is what Dr. Yogesh and others said. It is around 10 to 15% of my metastatic adenocarcinoma lung which are EGFR positive. So next question which I like to put to my panelists is, how do you investigate these patients for molecular tests? Do you send NGS, a comprehensive NGS for all, or do you just send RT-PCR for EGFR and ALK-IHC and then proceed? So this is what varies according to place, and this is very important because tissue is an issue and we sometimes have to make decisions. So how do you proceed in your practice? What do you do for most of your patients? Any of the panelists can take this question. Yeah.
So, most likely I will prefer NGS.
So you are doing NGS in most of the patients. Okay. So do you send a specific panel on a particular lab, or do you select a number of genes? And then if that is negative, then you send a comprehensive panel. What gene panel you use for NGS for most of your patients? Because sometimes when you send a extensive panel, you are worried about getting a unknown significance, variant of unknown significance, which may confuse our go. And now the companies are coming with more and more extensive panel, and sometimes rather than helping, it confuses us more.
Sir, like in between, not much extensive and not much basic, like in between, which send a NGS for that.
Okay. So in my practice, I'll see the affordability of the patient, and if he cannot afford a casualty person, I just send a EGFR for RT-PCR and ALK. And then does anybody have that type of patient who will have difficulty in affording later target therapy, so that your decision of sending a NGS versus RT-PCR or IHC differ in your practice?
Yes, Dr. Alok. Actually, I work in academic center, so most important thing is whether that mutation testing result is going to affect the treatment or not. So okay, NGS usually, because of affordability, most of the patients they are not affording. So rarely any patient is offered. But selective targeted mutation. Am I audible?
Yes, sir. Yes, you're very well audible. Very well audible, and a very relevant point you have made. So the companies are coming with an extensive NGS panel, but we need to look at our patient profile while deciding the test. We need to. So if you cannot provide a patient with a targetable therapy, there is no point of getting tested for n number of genes. So quickly moving on to the case. Yeah.
But I feel NGS is still important. It should be RNA based as well as DNA based, and it should cover all the relevant mutations, including the EGFR ROS and the different. Even KRAS is important, because even if many of time this might affect our decision for immunotherapy as well, even if the patient is not a candidate for the targeted therapy, Because we know that the immunotherapy will work poorly if the patient is having driver mutation.
Totally agreed, sir. Sir, in ideal patient, we all will like to do that thing, but sometimes we are just because of patient's economic status, and we have to make a choices which are less ideal than what we desire to do. Can we move on to the next slide?
That information regarding immunotherapy eligibility that can be available with select mutation only. EGFR, Cross1, and Pdl1. That's it.
Sure.
So that actually depends on whether we are planning any therapy to the patient or not.
Definitely, sir. So quickly to the panel. So this is the golden question which we are here to discuss. How would you treat your patient, this patient who is ECOG 0, a diabetic mellitus, EGFR mutant, L858R mutation? So what is the ideal choice? If money is not an issue with the patient, what will you choose and why? If we can quickly go into any panelist, they can start with what they do in your regular practice if the patient doesn't have any financial issues. Dr. Yogesh, if you want to start, please. Any of the panelists can answer this question.
Sir, osimertinib.
Okay, so you will go for osimertinib in a patient if affordability is not an issue. Any particular reason not for choosing a second generation TKI or a JEP plus chemo combination, which has also shown equivalent PFS to osimertinib in trial? It's a Tata trial, and it's very close to us also.
So maybe osimertinib will give the maximum OS benefit if we choose it as first line.
Okay. Any other panelists will like to differ on osimertinib? Anyone chooses anything else over osimertinib?
Yeah, Dr. Alok, I have a point to make. Like practically, yes, most of the patients end up getting osimertinib if they are not affording practically very good performance for patient. They are getting Geftonin plus chemotherapy. But I have one point regarding option of ramucirumab plus erlotinib, especially when PS is 0, is an excellent performance score, and mutation is L858R. So if you see the data, even with osimertinib in such patient, median PFS is relatively less. It was around 5.5 months. And if you see the data of relay trial, ramucirumab plus erlotinib, median PFS is more than 19 months.
Totally agreed, sir.
This patient is an excellent performance status, otherwise no other issues, no affordability concern. That is one of the options that can be explored.
So, but your comments on the difference in PFS if osimertinib is used in first line versus osimertinib used in second line, and how much of your patients of lung cancer go on to a second line therapy so that sequential therapy can get its actual OS benefit, which you expect, versus using a drug which has a maximum PFS upfront. Easy to give drugs.
Regarding this also, those patients who are on TKI, actually majority of them, they end up getting second line therapy.
Sure.
So those who are offered upfront cytotoxic, that's a different scenario. But those who are offered TKI, more than 80-90% of the patients, they actually get second line therapy. And the answer of the exactly category 1 evidence, that is also being studied in the ruler trial. So in a couple of years, that answer will also be there. But right now, that's also one of the options that should be explored, especially for very good fit patients with L858R mutation.
Totally agree, sir. Totally agree. Any other panelist has anything else? We are short of time, so we'll go to next slide. If
I would like to also go for osimertinib. It is an excellent CNS penetration as well, and it's a better OS benefit, PFS benefit, and excellent safety profile. I think the another choice might be decometinib, but it is less preferred because the tolerance issue and because of the CNS data has been excluded in the trial. That might be the reason for not choosing decometinib in patient. Afatinib is definitely inferior. Erlotinib has shown that osimertinib has shown superiority over them. So preferred choice should be osimertinib in this patient.
Okay. Can we go to the next slide, please? Next slide, please. So as most of our panelists have said, so as there are multiple category 1 options in NCCN to confuse all of our oncologists, but still because of the efficacy, output, the safety, they still give osimertinib the preferred category 1 option for patients, this type of patients. Next slide, please. So I have tried to put some of the factors which we use while we consider first-line therapy in these patients. We look for the efficacy of the drug, which we have enough data for third generation TKI, the safety, which is good with osimertinib, the quality of life, as well as overall survival. Is there anything else which any of the panelists like to add, which they look at when they try to choose therapy option in these type of patients?
Cost, but I think we are not supposed to discuss that.
No, we can discuss this. Academic discuss. We need to discuss. Most of our patients have cost issues, and we make decisions based on that. So yeah, very well said. Cost is one of the issues we need to think. And anything else? If not, we can go to next slide, please. Next slide, please. So this, if we look at the efficacy outcomes, and if we see various generation of TKI, the first generation, the second generation, third generation, we can see as we move on from first generation to the higher generation TKIs, there have been a significant increase in PFS and with the limitation of a cross-trial comparison, we can say that osimertinib has the highest PFS of all the lines of TKIs, with a very good hazard ratio of 0.46. And second thing, which already has been mentioned, that if we look at dacometinib, those trials have excluded all the patients with brain mets, whereas other trials for third generation and third generation trials have included stable brain mets patients. And we know almost 50% of patients with metastatic EGFR positive lung cancer will develop brain mets during their course of treatment. So that's a very important point which we need to see when we are deciding our therapy in this type of patients. Next slide, please. Next slide, please. Next slide. So as we all know that there is some difference between the efficacy of these patients. So we all know that exon 19 mutation patients do better with any type of TKI, and exon 21 L858 do badly, whatever be the TKI we use. But if we look at the osimertinib data, although the figure of PFS is lower for exon 21 as compared to exon 19, but still it gives a healthy PFS of 14.4 months, showing that osimertinib works across EGFR mutation types, although lesser in exon 21, as has been seen with all type of TKIs we have seen. So any comment on this thing? Any choice or any difference in choice when you have a patient of exon 19 mutation versus exon 21 mutation in front of you? Does your choice of treatment differ? Any of the panelists can take it. Yeah.
I think that in the DEL 19 with the CNS negative means patient, it doesn't have baseline brain mets, then afatinib also is a reasonable choice. I can't say it is better than osimertinib, but it is also reasonable. It gives OS of around 32 months or so, and 70% chances that patient will develop T790M mutation later on. So that will become candidate for the osimertinib.
Okay. So when you give afatinib, what dose most of your patients tolerate? My patient don't tolerate 40 mg. I have to reduce it.
Yeah,
what dose you use when you use afatinib?
Yeah, they end up mostly under 20 or 30. That's most of it. 40 is, I think, practically not possible for them to handle.
So, any other panelists will like to share their experience with afatinib or dacometinib? I have found them to be really difficult drugs to handle. These second generation EGFR TKIs. Any experience from any of the panelists of afatinib and dacometinib?
I have used afatinib in lung cancer and also in head and neck cancers.
Okay, sir.
And tolerability is usually not a problem if you're conscious of the dosing. I usually start them on 30. If they're tolerating well, I go up to 40. If they're not tolerating well, I come down to 20.
So do you think a new dose will reduce the efficacy, and what efficacy endpoints we are aiming for when we are looking at the endpoints?
Yeah.
Are we compromising them on when we are reducing a dose?
Possibly, but you have to look at what they can tolerate. I mean, head and neck cancer is not a problem because they are kind of into second or third line treatment. But in lung cancer, you want to give them the maximum efficacy. So I would agree you have to choose and balance that in lung cancer patients if you're talking about first line therapy.
Sure. Thanks a lot. Can we go to next slide, please?
You need to conclude.
I'm wrapping up. Next slide, please. Next slide. So if we look at the efficacy, overall response rate is also a very apt marker which tells us with the efficacy of drug. And here also osimertinib, we see 80% of the patient respond, and the duration of response is also very good, 17.2 months. Next slide, please. Next slide, please. Next slide, please. So, if we see among all the TKIs, osimertinib is one which has shown to have increase in OS as compared to first line TKI, showing a median overall survival of almost 39 months, with almost 54% of our patients surviving at 3 years as compared to 44%. And this is despite there's a healthy crossover. Almost 1/3 of patients have crossover in the control arm to osimertinib, saying that that despite crossover, osimertinib given in first line works and provides a significant overall survival benefit, making it an ideal choice when you are choosing in a relevant patient to give it. Next slide, please. Next slide, please. Next slide, please. So one thing I like to highlight, so with the Archer study, although numerically they have not studied it statistically, they have shown that OS, there's a higher OS, but because of the trial design, which is a hierarchical testing, because the overall response rate was not higher, so statistically they cannot test OS, and the OS could not be calculated from the Archer trial. So we can just say based on the Archer trial that the PFS, there's a PFS benefit of dacometinib, the overall response rate is not significantly higher, and thus OS cannot be measured, and we cannot say that OS is better in dacometinib as compared to first generation TKI. That need to be kept in mind when reading the Archer trial. Next slide, please. Next slide, please. We have already discussed that almost 50% of our patients will have brain mets. So osimertinib has a significant activity and has shown to improve CNS PFS in patients with EGFR mutant, making it a good choice for first-line therapies. So this is a question for all the panelists. Do you routinely do MRI brain in all patients of stage 4 lung cancer who are EGFR positive, irrespective of the symptoms? Any of the panelists can take this.
Yeah,
Yes,
most of the patients.
yes, we do.
Okay. Okay. So I think most of the panelists do it. I don't used to do it always 1 or 2 years back, but now with the guidelines from the NCCN also coming in, I also started doing routine brain MRI in all of the patients with EGFR mutant non-small cell lung cancer. Next slide, please. So as this mentioned, in 2021, NCCN also said that most of the patients should get a brain MRI prior to starting of treatment. Next slide, please. So as we have already discussed, the Archer study, which is the closest competitor in terms of the PFS, they have excluded patients with brain mets, which is a very important subgroup of patients in EGFR mutant. So the results of that trial, applicability to a general population and general patient type, becomes a little bit problematic in our system. Next slide, please. So if we see the CNS PFS with osimertinib has not been reached as compared to 14 months, and which is a very, very good plus point of osimertinib when using in these type of patients. Next slide, please. Next slide, please. This has already been discussed. Okay, those patients who had any driver mutation, they don't benefit from IO, and we need to wait for the mutation testing report when we are starting IOs in any of these patients. Next slide, please. Next slide, please. So this is the most important slide, which I will say after efficacy. It is safety, as we have already discussed. When we have a patient in the clinic, we just not look at the efficacy of the drug. We need to give a good quality of life and a good safety to the patient. And as all of our esteemed panelists know, that the discontinuation rate and the grade 3 toxicities are very high with the second generation TKIs, and it is least with osimertinib. Next slide, please. Next slide, please. So this is just to say that only 4% of patients had dose reductions or discontinuation in FLORA trial for osimertinib, whereas the same for afatinib and dacometinib was 52 and 66%, which is a thing of concern which we need to keep in our mind when choosing these type of therapies. Next slide, please. Next slide, please. So just to highlight that osimertinib is the only drug which has shown better scores in quality of life, and dacometinib and afatinib has not shown improvement of quality of life as compared to a first generation TKI, which is very important in metastatic lung cancer. Next slide, please. Next slide, please. Next slide, please. Next slide. So this is the question which usually come to my mind also when we are choosing that. If I start a patient on not on osimertinib upfront, do sequencing, putting osimertinib in second line will give us a similar OS or a better OS. So that question is answered partially by FLORA study, where almost 47% of patients has crossed over to osimertinib in the second line, and the first line osimertinib showed better OS as compared to second line osimertinib. So do you agree? Do the panelists agree that first line osimertinib do perform better as compared to giving osimertinib in a second line setting in all of these patients?
I think the data for the uncommon mutation is different. Uncommon and combined mutation, that might be different. Otherwise, we can say in the uncommon mutation, I think afatinib has shown better efficacy. Means common uncommon mutations, okay, like S768I and G719X and all.
Okay. Any other panelists, anything else, whether they will want to give osimertinib in second line, and if they feel that will give a higher OS or equivalent OS rather than giving osimertinib in first line, or the data is strong enough to you to convince your patient that osimertinib should always be used in first line?
For majority of the patient, first line osimertinib is most appropriate choice, considering it to be the most efficacious drug.
Okay. So that is what we also counsel our patients, that despite osimertinib working in second line, also giving a PFS of 10 to 11 months, and that's the big question: what after osimertinib if osimertinib fails? And a lot of trials which are coming up now, and a lot of therapies which are in pipeline post osimertinib. We hope that even after osimertinib, we will take that OS even higher in years to come. Next slide, please. Next slide, please. Next slide, please. Yeah. So this is a very interesting study which was published in Future Oncology in 2019, and this was GeoTap study which compared first line afatinib followed by osimertinib. It's a retrospective study and showed around 40 months of OS benefit. I would like to ask my panelists comment or opinion on the GeoTap study, what they think about this sequencing of afatinib followed by osimertinib, or are they happy using osimertinib in first line despite this result? If any of the panelists can take it. So there was a lot of issues with the GeoTap study. It's a retrospective study. Almost 79 to 80% of patients had exon 19 deletion, which has a good performance status, and they have taken those patients only who have OS of who had already on osimertinib for 10 months, which shows that they are good prognostic patients. So that GeoTap study still doesn't answer the question whether osimertinib first line or second line will be better. So with all the data which we have, as we have summarized, osimertinib as of now seems to be the preferable option in first line in terms of the efficacy, the CNS penetrance, the quality of life issue, and safety. And we need further data if we need to comment on using anything else in practice over osimertinib. I'd like to thank all of our panelists for active work, and I'd like to thank again the organizers for inviting me for this. Thank you, and I'm sorry for shooting the time if I have.
Thank you, sir. Thank you so much. Thank you for your excellent panel discussion. And next we move on to the topic, establishing osimertinib as SOC in the management of EGFR positive NSCLC real world evidences. And for this, I would like to invite Dr. P. Venkatesh Rao, who is consultant medical and hemato-oncologist, Omega Hospital, Visakhapatnam. Over to you, sir, for your talk.
Good evening, everyone. Is my screen visible?
Yes, sir.
Yes, sir.
Okay. So we had a wonderful panel discussion. We'll go ahead with this real-world evidence on osimertinib as standard of care in management of EGFR mutated NSCLC. Thank you, organizers, for this opportunity. So osimertinib was initially developed for second-line therapy in T790M mutated patients of EGFR mutated stage 4 lung cancer patients, and later it was studied in first line in this FLORA, which is a phase 3 RCT comparing osimertinib with erlotinib or geftinib in first line metastatic stage 4 NSCLC. And as it has already been discussed, there was a significant PFS improvement with osimertinib, which was 18.9 months compared to 10.2 months in the comparator arm. And as we can see, the curves had started from the very beginning. And in all the subgroups, there was a benefit with osimertinib when compared to first-line TKI. However, as already discussed, EGFR exon 19 deletion patients had better HRs when compared to L858R patients. And it also had worked very well in patients with brain metastasis. The very next year, they had also published the OS data, and osimertinib showed a significant improvement in OS of 38.6 months when compared to first-line TKIs, which is 31.8 months, despite a significant crossover. Now, from this data, both the NCCN and ESMO have concluded that osimertinib be preferred for first-line therapy in stage 4 EGFR mutated NSCLC. We all know that these RCTs may not represent the real-world population. Only good performance status patients are selected for clinical studies. So we also need to know the real-world evidence. And here we have 3 studies, Flower, OSIFACT, and Mycona studies, which are real-world studies using osimertinib. To start with, the Flower study is a prospective observational study of first-line osimertinib in stage 4 NSCLC. So it was conducted in around 126 patients, and majority were females, similar to most of the studies, and around 2/3 was non-smokers. And we can see that 30% of patients had brain metastasis when compared to only 19% in the FLORA study. And exon 19 and exon 21 deletions. Exon 19 deletion was in 50% and L858R in around 43% of patients. And around 12% of patients had a PS greater than or equal to 2. These patients are usually excluded in these clinical trials. And here we can see that around 73% of patients had a partial response, 23% had a stable disease, and 4% progressed. So the primary assessment was TTD, which is time to treatment discontinuation. So in studies where we use osimertinib, time to discontinuation seems to be a suitable endpoint rather than PFS, since we tend to use osimertinib beyond progression, especially for oligoprogressive disease, where we locally address the disease followed by continue osimertinib. So time to disease progression was around 25.3 months in this study. And they had also compared time to discontinuation in patients who were asymptomatic versus those who were symptomatic, and those who had less than 3 metastatic sites versus those who had more than 3 metastatic sites. And as you can see from curves C and D, the median time to discontinuation was not reached in asymptomatic patients, whereas it was 18.8 months in patients who had symptoms. Similarly, it was not reached in patients with less than 3 metastatic sites, and it was around 21.4 months in patients who had more than 3 metastatic sites. They also published the PFS data, and median PFS was 18.9 months, similar to that seen in FLORA. And also PFS was better in patients with no brain metastasis and patients who were asymptomatic at presentation. They also published data regarding time to biopsy, time to pathologic report from biopsy, which was around 7 days median time, and similar to seen in our practice. And median time from pathology report to EGFR mutation status was 8 days, and median time to start osimertinib was approximately 17 days. Around 44 patients had progressed in those 126 patients, and among these 44, 21 patients underwent a rebiopsy, of which 2/3 had a tissue biopsy and 1/3 were a liquid biopsy. Molecular analysis was performed in 13 samples, and what they found was four patients had a MET amplification, one patient had a MET amplification and EGFR amplification, one patient had EGFR amplification, and one patient had HER2 amplification. So all these are targetable resistance mechanisms for EGFR mutation, and we have to check for this, but unfortunately, we usually don't do it. Coming to safety, majority of side effects were diarrhea, rash, dry skin, and paronychia, similar to what we usually see. But what was noticed in this study was around 9.5% of patients had venous thromboembolism. 7.9% had grade 3, grade 4 venous thromboembolism. And also ILD or pneumonitis was seen in 9.5% of patients, with approximately 2.4% having grade 3 or grade 4 pneumonitis. And this in venous thromboembolism, there was no difference in rates when compared according to age, performance status, or comorbidity, which indicates that probably this VTE could be related to drug. However, this adverse event wasn't reported in FLORA study. The efficacy was similar to FLORA, but there was an extra adverse event which was seen in this study. Moving on to next study, it is OSIFAC study. It's a retrospective observational study from Japan. And this study had huge number of patients, around 538 patients, with age distribution and gender distribution, smoking status similar to that of what was seen in FLORA. Around 50% of patients had exon 19 deletion and 45% L858R. And they also stratified patients according to Pdl One status. And around 12% of patients had a Pdl One greater than 50%, 31% with 1 to 49% Pdl One TPS, and less than 1% having 30% of patients had less than 1% Pdl One TPS. The median PFS in this study was 20.5 months. And when multivariate analysis was done, patients who had malignant effusions or liver metastasis or brain metastasis had a lesser PFS. Similarly, they had seen that in patients who had a Pdl One TPS of greater than 50%, they had a HR of 2.24. That is, PFS was less than half of what was seen in patients with less than 1% Pdl One status. And as the Pdl One status increased, the PFS had decreased. This was not studied in FLORA, and though it's a retrospective study, it needs proper validation. We need to find out whether really Pdl One status affects efficacy of osimertinib. Coming to adverse events and treatment discontinuation, around 44.3% of patients discontinued due to disease progression, and 25.6% of patients had discontinued due to pneumonitis. So pneumonitis was significantly seen in this Japanese population, and remaining 16% of patients had other adverse events like anorexia, skin disorders, QT prolongation, fatigue, anemia, and all. However, the point to note here is a high incidence of pneumonitis in Japanese patients. So to conclude, the overall response rate was 76.2% and disease control rate of 94.1%. PFS was better with osimertinib, similar to that seen in FLORA, though it was irrespective of Pdl One status, but Pdl One status did affect the HRs for PFS. Median time to treatment failure was 19.1 months, and the discontinuation rate due to adverse events was 18.8%, and especially pneumonitis was high in this series, and it requires further investigation. Coming to the last study, Mykonos study, it's a prospective real-world study of EGFR mutated locally advanced or metastatic NSCLC. It was a global observational study conducted in US, Europe, and Asia. However, this data is from US Flatron Health electronic health records from around 280 US clinics, and inclusion criteria include more than 18 years of age, stage 3B or 4 NSCLC with EGFR mutations. And data was collected through Jan 2020, and study is still ongoing. It was a sub-analysis from US population. And the outcomes were TT-NTD, which stands for time to next treatment or death, and TTD, which stands for time to treatment discontinuation, as we had already seen for other studies. So among 548 patients who were started on first-line osimertinib, around 58%, that is 318 patients, remained or were lost to follow-up when this study was analyzed. And 18.8% of patients had received second-line treatment, which included PD-1, Pdl1 combo or monotherapy, or EGFR TKI monotherapy or a combination, or a platinum-based chemotherapy. Around 18.4% patients had died while on first-line therapy, and 4.7% discontinued first-line therapy.
My
the
apologies,
real-
sir. You are just left with 1 minute to conclude your presentation.
Okay, yeah. So at a median follow-up of 9.6 months, median time to next treatment or death was 17.9 months. And factors which affected this outcome were stage at initial diagnosis. Smokers had a poorer PFS, and patients with poor performance status and patients with L858R mutation or more than 4 metastatic sites had a lesser time to next treatment when compared to the other patients. Similarly, time to next treatment discontinuation was 17.2 months, and factors like comorbidity status, performance status, EGFR mutation type, and number of metastatic sites had impacted on outcome. So to conclude, the study provides real-world insight into use of first-line osimertinib in advanced NSCLC patients, and the data showed that outcomes were similar to that seen in FLORA. So all these trials had matched the efficacy of osimertinib FLORA. However, the adverse events were slightly more, with 2 events to be notified were venous thromboembolism as well as ILD or pneumonitis, which need to be observed, and the caution has to be taken. However, with a handful of patients which I have treated, I haven't faced any of these problems. So I conclude here. Thank you. Thank you once again, organizers and AstraZeneca
Thank
for
you,
this
sir.
opportunity.
Thank you so much. Thank you for the wonderful talk, sir. And the upcoming session is sponsored by our academic partner, Roche. And for this, I would like to invite Dr. Raghav Kesri, who is consultant medical oncologist, Metro Hospital, Faridabad. And he's going to speak on role of atezolizumab in 1L MNSCLC. Over to you, sir, for your talk. Hello. Hello.
Sir, you need to unmute, sir. Raghav, sir, you need to unmute.
Yeah, is my screen visible now?
Yes, sir. Screen is visible. You need to make it full screen, sir. Yes, sir. Is it full screen? It is full screen now. You can proceed, sir.
Right. Good evening, everyone. I am going to speak upon the role of atezolizumab in the first-line treatment of non-small cell lung carcinoma. We do realize that lung cancer is an extremely evolving landscape, and we currently have got a lot of options available now for the treatment of the disease. Now we would be covering the following topics. We would start with covering the disease background, then the evolving landscape of lung cancer treatment, then these 3 studies, Iron Power 110, Iron Power 150, Iron Power 130 study, right? So if we start with the introduction of non-small cell lung cancer, So non-small cell lung cancer is actually a slow-growing tumor with very varying initial overall response rate. Now that depends upon the driver mutation as well as the targeted therapy. Another thing to realize is that it constitutes about 80 to 85% of all lung cancers. The median age of presentation is 70 years, and around 15% of the patients are never smokers. Now, in the patients who present with the disease, around 55% of the patients at diagnosis have metastasis, right? And over the period of the past few decades, the targeted agents have improved the survival rates also, especially in the patients with the driver mutations.
Dr. Raghav, you have muted yourself again.
Sir, actually, my slide, I'm not able to toggle through it.
Can I share from my side, Raghav sir?
Yeah, so I think, yeah, now it's working. So if we talk about the evolving landscape of the lung cancer, in 1980s, the only options that were available to us were chemotherapy. At that time, basic distinction among between the non-small cell and the small cell lung carcinoma was also not available with terms of chemotherapy. Gradually, as we reached the 90s, based upon the histological subtype, the chemotherapeutic agents were also subdivided. And gradually in 2000s, we discovered EGFR cross on all the targeted mutations, and targeted therapy was developed. And recently, in the past 10 years, we have now developed checkpoint inhibition and are now using cancer immunotherapy, which has actually revolutionized the treatment of lung cancer. So another thing to realize is that we do have a lot of actionable markers. Now, if you see the subdivision here, among all the cases of lung cancer, 29% were found to have KRAS mutations, which have only recently become targetable. Then we have got EGFR mutations in 11% of the patients, and ALK mutations in 5% of the patients. In a significant proportion of the patients, that is 35%, there is no significant actionable biomarker, right? As of now, it has not been discovered. And with the advent of targeted therapies, there has been a significant change in the overall survival. So with the targeted therapy, we are able to achieve an overall survival of around 32 months. With just the cytotoxic therapy, it's only around 12.7 months. So as you can see that the advent of targeted therapy has led to the almost, there is 19 months of OS benefit. So now we will be talking about the role of atezolizumab. The following trials, IMpower 110, 130, and 150 will be covering. The first trial to cover is IMpower 110, which actually compares atezolizumab monotherapy with the conventional chemotherapy agents in Pdl One selected chemotherapy naive patients. So if we look at the trial, it was a phase 3 multi-center study. The inclusion criteria was all cases of stage 4 non-squamous or squamous NSCLC who were chemotherapy naive, EGFR cross negative. Pdl1 calculation was also done on all the patients. The platform used was Vendana SP142 assay, and the stratification was done on the basis of sex, the performance status, histology, as well as the Pdl1 IHC expression. So the patients were divided into 2 groups, 1:1 ratio. The first group was given atezolizumab at 1200 mg Q3 weekly. The second group in non-squamous patients, carboplatin or cisplatin plus pemetrexed was given, followed by pemetrexed maintenance. In the squamous group, platinums plus gemcitabine were used, and there was no crossover permitted in the trial. And the maintenance therapies were continued as long as there was no progression in the disease or the patient was unable to tolerate the therapy. If we talk about the prevalence of PDL1 in the two arms, PDL1 expression in the two arms, you can see here that the division was almost comparative between the two arms. The patients with high PDL1 status were around 38.6% in the atezolizumab arm and 35.4% in the chemotherapy arm. The patients with more than 5% tumor cell or infiltrating cell PDL1 expression were again 59.9% in the atezolizumab arm and 58.5% in the chemotherapy arm. Now, if we talk about the baseline characteristics, they were also well balanced between the two arms, as you can see in this table. So they were equally, almost like equitably distributed in terms of age to sex ratio, as well as the histologies that were seen. Same with regards to the performance status also. Now, if we talk about the OS benefit in this trial, so this trial, if we will see median OS benefit of around 7 months was seen in the atezolizumab arm. So the median OS was around 20 months was seen with atezolizumab, and median OS of 13 months was seen with just the chemotherapy part. Now, this benefit was practically seen over all the subgroups. Now, if we see about the progression-free survival, a clinically significant PFS benefit was seen in the atezolizumab arm. The PFS benefit of almost 3 months had been seen in the atezolizumab arm. Now, if we talk about the safety profile, now you'll notice here that the number of adverse events was obviously, as we would expect, more in the chemotherapy arm than in the immunotherapy arm. And but the number of immune-mediated adverse effects, again as expected, was more in the atezolizumab arm than in the chemotherapy arm. So if we see the overall tolerability of atezolizumab arm was better than the chemotherapy arm. Now, if we talk about the side effect profile, the most common side effects that were seen in the chemotherapy arm was anemia, nausea, neutropenia. And in comparison to the atezolizumab arm, even atezolizumab arm showed these the commonest side effects, anemia, nausea, etc. But if you see, the proportion was significantly very less in the immunotherapy arm. Conversely, in the atezolizumab arm, there was an increased amount of AST elevation, pruritus, as well as the hypothyroidism, which again are known and expected autoimmune side effects. But these were also all mostly manageable with the use of steroids. So summarizing this trial, based upon this trial with patients with PDL1 high NSCLC, atezolizumab was a promising first-line treatment option. And atezolizumab also had a favorable safety profile compared with the chemotherapy arm. And the treatment exposure in atezolizumab arm was more than the chemotherapy arm. Next, I would like to go to IMpower 150 study. So this was a phase 3 study where atezolizumab was added to chemotherapy and bevacizumab in first-line advanced non-squamous non-small cell lung carcinoma. So the key clinical questions that it addressed was whether the addition of atezolizumab to the standard of care bevacizumab plus taxane and platinum added a clinical benefit, and was there any clinical benefit if bevacizumab was replaced by atezolizumab. So the patients that were taken were stage 4 non-squamous non-small cell lung carcinoma, chemotherapy naive patients with stratification on the basis of sex, PDL1 expression, and the liver mets. Now we talk about the endpoints that we were assessing was the progression-free survival as well as the overall survival between the arms. So if we see then in this trial, the patients were divided in 1:1:1 ratio. In the first arm, it was atezolizumab plus pacli plus carbo. Second arm had 4 drugs, atezo, carbo, pacli, and bevacizumab, and third one only had bevacizumab plus chemotherapy. Respectively, the maintenance was continued with only atezolizumab in first arm, atezo plus bevacizumab in the second arm, and bevacizumab only in the third arm. It was continued till there was PD or loss of clinical benefit. Now, the rationale behind adding all these was, first of all, chemotherapy would lead to the death of the cell and release of tumor antigens. Atezolizumab, in turn, would the release of the tumor antigens would lead to triggering of the immune response. This inhibition of immune response would be suppressed by atezolizumab, and bevacizumab in turn would also inhibit VEGF mediated suppression of the immune response. Now, if you see again, the baseline characters were well matched between the arms. Another thing to note in this trial was that patients with EGFR ALK mutation were also taken. Only those patients with EGFR ALK mutations were taken who had either progressed on first-line TKIs or were unable to tolerate TKIs. Upfront EGFR ALK mutation patients were not offered the treatment. So if we compare the two arms, then overall, if we look at the overall survival, then overall survival benefit of almost median OS benefit of almost 5 months was seen in the atezo plus bev plus chemotherapy arm. If we compare it to just the bevacizumab. Now, if you see that the median OS benefit of 4.5 months was seen, if we compare it on the basis of the Pdl1 expression, overall also in patients with Pdl1 high, the overall response rate of 69% was seen. In the B arm, that was atezo plus chemo plus bevacizumab in comparison to the bevacizumab plus chemotherapy arm. This benefit was also seen in the patients who were Pdl1 low as well as Pdl1 negative. Also, if you see, the median duration of response was higher in B arm compared to the C arm. Like the B arm would be your immuno plus chemo plus bev, and C arm would be just bevacizumab plus chemo. Now, if we compare the OS between the patients in terms of Pdl1, maximum benefit was seen in patients who were Pdl1 high. If you see, there was a OS benefit of almost 10 months in the patients who were Pdl1 high, but even in the Pdl1 negative patients, around 3 months OS benefit was obtained. Now, coming to the patients who were EGFR positive and had progressed on tyrosine kinase inhibitors, if you will see that the curves, they started separating at around 6 months, and again we could see the benefit of almost 3.5 months in the patients who were EGFR positive in the atezo plus bev plus chemotherapy arm. Now, if we talk about the OS benefit in patients with the mutations, then again the benefit of around 11 months was seen between the two arms. But this benefit was actually not very significant in arm A versus arm C. Now, overall response rate was increased by from 42 to 71% with the addition of atezolizumab to bevacizumab plus chemotherapy. The median duration of response in atezo arm was 11.1 months, and it was around 4.7 months in bevacizumab plus chemotherapy arm. Now, coming to the patients of liver metastasis, again we had a PFS benefit of almost around 3 months in the patients with liver metastasis. So this is significant as liver metastasis by itself is a significant negative prognostic factor. Now, again, the benefit was in OS was seen in arm B versus arm C. That would be atezo plus bev versus only bev plus chemo. In the arm where atezo plus chemotherapy compared with bev plus chemotherapy, the significant benefit was not seen actually in patients with liver metastasis. OS benefit again was seen in patients of liver metastasis, and OS benefit of almost 4 months was seen in arm B versus arm C. Now, the overall response rate as well as the duration of response was higher in atezo plus bev plus chemotherapy arm if we compare it only with bevacizumab plus chemotherapy arm in patients with liver metastasis. Now, if we talk about the patients with bulky disease was defined as patients having high disease burden or low disease burden. High disease burden was where you had more than 2 metastatic sites. Median here is 2 sites. So more than 2 metastatic sites was more than equal to 2 metastatic sites was taken as high disease burden. and less than 2 metastatic sites was low disease burden. This benefit was also translated in high as well as low tumor burden sites. In both the scenarios, the median OS benefit was obtained. However, in the low burden sites, the benefit was almost of just a month, the median OS benefit. But in the high burden sites, it was almost of 5 months. So now this data supports the use of atezo plus bev plus chemo as the first line in bulky disease. Now, if you see, then the degree of adverse effects was equivalent in all the arms. So in the previous study, if you remember, in the immunotherapy arm, the adverse effects were significantly lesser. But here, actually, the greater proportion of side effects is actually expected in the B arm and all the arms because chemotherapy was a part of all the arms. And if you will notice, then the immune related side effects was significantly higher in arm A and arm B in comparison to arm C. So between all these three, the high amount of adverse effects were seen. So as you can see, then IM power 150 was a positive study. It showed statistically significant improvement in the endpoints of OS as well as PFS with the addition of atezo to bev plus chemotherapy arm. And as well as if you talk about the safety profiles, then the safety profile of both the arms was almost similar. So now if we come to the, now I will come to the next study, that is IM power 130. IM power 130 was a phase 3 study where carboplatin and nab-pac, there were actually chemotherapy plus immunotherapy combination was done. The rationale used behind it was that chemotherapy again would lead to the cell death and release of tumor antigens, and the release of tumor antigens would lead to triggering of T cell activation. So the T cell deactivation caused by Pdl1 would be suppressed by atezo, which in turn would create a more favorable microenvironment for action against the tumor. So again, if we talk, so we here non-squamous, non-small cell lung carcinoma stage 4 patients who were chemotherapy naive were selected, and they were stratified on the basis of Pdl1 expression, liver mets, and the sex. So there were two treatment arms. One was atezo plus carbo plus nab-paclitaxel. Other was the chemotherapy arm of just carboplatin plus nab-paclitaxel. The atezo plus chemo arm was followed by atezo maintenance till PD or loss of clinical benefit, and the carboplatin plus nab-paclitaxel arm was followed by pemetrexed maintenance. So in this, there was, I think, that crossover was permitted from initially from arm B to arm 8 was permitted. Later on, it was not permitted. But in spite of that, 41% patients in the control arm crossed over to atezolizumab. So even in the control arm, 59% of the patients ended up receiving chemoimmunotherapy. Now, if we talk about the baseline factors, they were again well divided between the two arms. So if we talk about the results of the study, progression-free survival, median PFS benefit of 1.5 months was seen. But at 12 months, the PFS benefit of 29.1% versus 14.1% in the chemotherapy arm was seen. So if you see that the addition of atezolizumab to the chemotherapy led to the doubling of 12-month PFS. Now, if you talk about the OS benefit, we had an OS benefit of almost 5% in the patients who were given atezo plus chemotherapy. So this was seen in spite of the fact that 59% of patients in the control arm had shifted to chemoimmunotherapy. Now, if we see, then the median OS benefit was again reproducible along all the subgroups, even among the Pdl1 high, low, as well as the Pdl1 negative subgroups. Now, if we talk about the overall response rate as well as the duration.
My apologies, sir. You are left with 1 minute to conclude your presentation.
So if you see this slide, then the duration of response was higher in the atezo plus platinum arm. Talking about the proportion of adverse effects, the number of adverse effects was more in the number of adverse effects was comparable between the two arms because of chemotherapy being the part of both arms, with a significant proportion of increased autoimmune side effects in the patients who were receiving atezolizumab. Now, to conclude, IM Power 130 was a positive phase 3 study, which provided significant OS benefit when atezolizumab was added to carboplatin plus nab-paclitaxel. Higher overall response rate PFS benefit was seen. And one thing about this study was that in this study, again, EGFR ALK positive patients were taken, the ones who had progressed on TKIs, but in this, the benefit was not seen in the EGFR ALK positive patients. So with this, I would like to conclude, and I would like to thank everyone for this session. Right.
Thank you. Thank you, sir, for your enriching session. And for the upcoming session, which is sponsored by our academic partner, Pfizer, I would like to invite Dr. Kaushal Kalra, who is consultant medical oncologist, VMMC at Safdarjung Hospital, New Delhi. And he's going to talk on management of first-line ALK plus NSCLC. Over to you, sir.
Yeah. The slides are visible.
Yes, sir.
Yeah. So am I audible to all?
Yes,
Hello.
sir. It's audible.
So first line management of ALK rearranged non-small cell lung cancer. So first we'll come to the incidence of lung cancer in India in 2020. Approximately 72,000 patients were diagnosed as a CA lung, and out of this, 67 patients got mortality in 2020. In North Indian patient cohort, ALK gene rearranged lung adenocarcinoma was approximately 7% after the EGFR and KRAS mutation. In the timeline, the ALK rearrangement with the EML4 translocation was discovered in 2007, and crizotinib, which was the first, got approval in 2012 as the first generation ALK inhibitor. And after next 6 years, we got another ALK inhibitor, second generation, like ceritinib, alatinib, brigatinib, and they were approved also. In 2019, third generation lorlatinib was discovered and got approval in 2021 for use in first line, ALK inhibitor. So ALK rearranged non-small cell lung cancer is 3 to 5% of all advanced non-small cell lung cancer, and which are more common in the younger patients and never or light smokers in adenocarcinoma histology. Squamous also they can present, but very rare. So first generation ALK inhibitor is crizotinib, second generation is ceritinib, alatinib, and brigatinib, and third generation lorlatinib. As per generation, potency and activity against ALK mutations are increased, and CNS penetration also improved. First, come to the first generation ALK inhibitor crizotinib, the profile 1014 trial, in which crizotinib was compared with the chemotherapy, standard chemotherapy, pemetrexed and carboplatin, and PFS was 11 months versus 7 months, which was statistically significant. And in updated OS data, this median OS was not reached in crizotinib arm, while it is in chemotherapy, it's approximately 4 years. And in Ascent 4 trial, and PFS was almost double, 8 versus 16 months. OS data is also not estimable. The hazard ratio is 0.73 in updated data. The alectinib in Alex study was compared with the crizotinib. Previous two were compared with the chemotherapy, while this was compared with the crizotinib, already established ALK inhibitor. In this, PFS was increased up to 4 times, 11 months versus 35 months. in both the arm. Alectinib is better than crizotinib, 34.8 month versus 10.9 month PFS. Overall survival is immature with the hazard ratio is approximately 0.67. So these are the randomized trial of the first and second generation TKI we discussed in ALTA-1L trial. Brigatinib was compared with the crizotinib, in which PFS was almost double, 11 month versus 24 month. Now, this lorlatinib was rationally designed to address the unmet needs in the ALK positive NSCLC. These unmet needs were first metastatic brain disease. In untreated ALK positive NSCLC, approximately 20 to 40% patient got brain metastasis. And the second need was the acquired resistance to the already established ALK TKIs. For these two needs, lorlatinib was designed. And this lorlatinib has effective CNS penetration and retention. And second point, it binds with a very high affinity to the most ALK-resistant mutation. Crown study was done, it's a phase 3 trial, compared with the crizotinib. Lorlatinib is compared with the crizotinib. Key eligibility criteria is stage 3B to 4 ALK positive NSCLC, chemo naive or treatment naive patient with a good performance status with the asymptomatic brain mets. Randomized in the ratio of 1:1 and stratification done by presence of brain metastasis and ethnicity, Asian versus non-Asian. Primary endpoint was the PFS, progression-free survival, by the blinded independent central review. Baseline characteristics were well matched between the both arms. So now come to the 36-month follow-up data, which are presented in 2022 only. In ITT population, we can see 3-year PFS is 63.5%, approximately 3.5 times, more than 3.5 times in comparison with the crizotinib. In crizotinib, it's only 19 months, and median PFS is still not reached. While it is in crizotinib, it's 9.3 months. And overall response rate was 77 versus 58, almost 1.5 times. And median duration of response is not reached in the lorlatinib versus it is less than 1 year, 9.6 months in the crizotinib. And we can see in this subgroup analysis, in each and every subgroup, lorlatinib performed much better than the crizotinib. Each subgroup, including whether brain mets present or not, whether Asian or non-Asian, whether male, female, or age, smoker or former smoker, metastatic, and adenocarcinoma. Each subgroup, lorlatinib performed much better than the crizotinib. So BICR, blinded independent central review, assessed PFS. We can see it is better in the lorlatinib. It has not been reached. Median PFS has not been reached in the lorlatinib arm. In both conditions, whether it is brain metastasis present or without brain metastasis. You can see with brain metastasis crizotinib arm, median PFS is 7.2 months, while in lorlatinib, it's not reached. Similarly, in without brain mets, it's 11 months in crizotinib arm, while it is not reached in the lorlatinib arm. Time to intracranial progression was also significantly longer in the lorlatinib. You can see in 36 months, at 36 months, 92.3% versus 37.7%. It is almost 3 times better in the longer in the lorlatinib. And this is BICR assessed intracranial time to progression in patient with a baseline brain metastasis. Median PFS is not reached in lorlatinib, while it is 7 months in crizotinib. And when there is no baseline brain metastasis, crizotinib arm, it was median PFS of 30 months versus 7 months, while it is not reached in both the condition in the lorlatinib arm. So in summary, overall response rate is 77.2% versus 58.5%, better in the lorlatinib, and complete response is almost only 2%. While in the patient with the brain metastasis at the baseline, confirmed intracranial overall response rate was 65% versus 17.9%, almost 4 times better in the lorlatinib arm, and complete intracranial response was seen in 60% of the patient. Now come to the adverse event. Adverse events are comparable with the crizotinib. Grade 3 and grade 4 adverse events were 75% versus 57%. slightly higher in the lorlatinib arm, and the treatment-related death was in 2 patients in lorlatinib arm, while there was no treatment-related death in the crizotinib patients. Temporary discontinuation is also more in the lorlatinib arm. However, permanent treatment discontinuation are more in crizotinib, which are almost similar. In safety profile, edema, weight gain, hypercholesterolemia, hypertriglycemia, peripheral neuropathy, and cognitive effect, these adverse events are more in the lorlatinib arm. While diarrhea, nausea, vomiting, vision disorder, transaminitis, these side effects are more common in the crizotinib arm. So safety profile of lorlatinib was similar to that reported in the interim analysis of the 18 months. So we have not faced any new safety challenges during these 18-month further follow-up. So this is a slide for the summarizing the 18-month versus 36-month lorlatinib arms. PFS is hazard ratio is 0.28 versus 0.27. Overall response rate is 77%. Time to intracranial progression hazard ratio is also 0.08. Intracranial response rate 59.5%. And adverse event leading to permanent treatment discontinuation was 7% was at the 18th month, and while it is only 7.4, only 0.4% increased. So now we can compare the first line, all first line LPKs each other. You can see in this side we can see overall response rate as best in the alectinib. Apart from this, in each and every aspect, lorlatinib performed better. You can see CNS CR rate is 38% in alectinib, 11% in brigatinib, while it is 71% in the lorlatinib. And median PFS is also approximately 24 to 25 months in alectinib, brigatinib, and certinib, while it has not been reached in the lorlatinib as per the Crown trial. These the summary of the principal adverse event of the different first line LTKI, alectinib, brigatinib, and certinib, and lorlatinib, and we can optimize the treatment as per the treatment profile. Now, network meta-analysis systemic review was done to compare the lorlatinib with the brigatinib and alectinib, and in this network meta-analysis, it was seen that lorlatinib is better than brigatinib and alectinib in all the treatment-naive patient. So in Indian data for the lorlatinib in Indian center, we can see when lorlatinib was given in this previously treated patient and was 41. This study was done in Tata Memorial Hospital, and we can see clinical benefit was 73% patient, 73% of the patient. This is updated NCCN guideline. The patient with the ALK rearrangement. If patient was diagnosed before the starting any treatment, then preferred first line treatment is alectinib, brigatinib, lorlatinib, and ceritinib. And if patient already started on the first line systemic therapy, then first we have to complete the planned systemic therapy, including maintenance therapy, or we can interrupt followed by this thing, alectinib, brigatinib, lorlatinib, ceritinib, and any first line ALK inhibitor we can start. So this is the treatment landscape, which is rapidly evolving due to new invention, new drugs. You can see previously sequencing was done with the crizotinib followed by ceritinib, then lorlatinib, crizotinib, alectinib, lorlatinib. Now we can see at the baseline lorlatinib and the first line PFS is better than all these sequential therapies of the ALK inhibitors. So in conclusion, with approximately 18 months of the additional follow-up since the interim analysis of the phase 3 Crown study, lorlatinib continued to show the superior overall and intracranial efficacy in comparison with the crizotinib in ALK positive patient. And these benefits is seen in the both whether the patient has baseline brain metastasis or not. And there is no safety signal, but we have seen. So these updated long-term data from the Crown study confirm the efficacy of lorlatinib over crizotinib in patient with treatment-naive ALK positive NSCLC. Thank you.
Thank you, sir.
there any question?
Sir, thank you for your excellent talk. And next we move on to the next talk, which is sponsored by our academic partner, BMS. And for this, I would like to invite Dr. Novak Gupta, who is Consultant Department of Medical Oncology and Hematology, ESIC Medical College, Faridabad. And he's going to speak on long-term survival outcomes with nivolumab in MNSALC. Over to you, sir.
Can you please share my slides?
Ritika, can you do that?
Okay. Good evening, everyone. I'm Dr. Novak Gupta. I'm a medical oncologist at ESI Medical College, Faridabad. And first of all, thank you organizers for giving me this opportunity, and thank you BMS. So the talk given to me is long-term survival outcomes with nivolumab in metastatic NSCLCs. I'll be quite brisk. We are running short of time. We are already, I think, 15-20 minutes late. So with this, next slide. So first of all, we'll be talking about the Nhlc overview and the treatment landscapes, and then we'll be discussing the Checkmate 017 and the 057 and the 5-year outcomes. Next slide. So this is the epidemiology of lung cancer. The disease by far accounts for 13% of all the cancer diagnosis, and it accounts for about 19% of the cancer mortality, which kind of equates to the mortality of the colorectal, breast, and prostate combined. Now, this is the worldwide data. When we're talking about the males, it accounts for 24% of the cancer mortality and 14% of the cancer mortality in the females. Next slide. So coming to the histology and staging, next slide. So broadly, the lung cancer is divided into the small cell, which is about 10 to 15% is a deadly disease, and we'll be not talking about it. We move to the NSCLCs, which is the bulk of the disease and accounts for about 80 to 85% of all the lung cancers, which is further divided into various histologies depending upon the size, the shape, site of origin, the rate of growth, and the relation to smoking history. Next slide. So overall, the problem with lung cancer is most of the patients present with an advanced disease. The early stage, which is the stage 1, stage 2, accounts for about 15% of the patients. The stage 3 accounts for about 22. The previous slide, yeah, not that fast. Okay, so the stage 3 accounts for about 22% of the NSCLC patients, whereas the advanced disease, the stage 4, accounts for the bulk of the patients, which is about 55 to 60% of the patients. Next slide. So this is the TNM class staging, the early stage, which is stage 1, stage 2, the stage 3, 3A, 3B is the locally advanced and the metastatic disease. Next slide. So now this is the epidemiology of the lung cancer. When we're talking about our country, there's the Indian data. The disease accounts for about 72,000 new cases, with an annual incidence of about 5.5 per 1 lakh per year. The deaths of about 66,000 and a 5-year prevalence of about 80,000. Next slide. Now coming to the second line, we've seen a huge paradigm shift, and I think even in this, we've been talking about the changes in the first line treatment of advanced NSCLCs, and we have really seen a paradigm shift in the management of our advanced NSCLC patients in the last few decades. The reason for is the number of newer drivers and the drugs coming into being added to our armamentarium daily. But what is important is what we'll be talking today is the second line, which is when the patients, all these patients eventually progress. That is when the things become gray. So overall, docetaxel has been the second line approved therapy, which was approved by the FDA somewhere around 2017 or 2018. Now targeting the Pdl1 axis is something again very important, and we've seen great results, especially in the first line setting. So similarly, even in the advanced second line or later lines of therapy, the targeting the Pdl1 axis is very important. Next line, next slide. So now, what are the treatment considerations when we are talking about treating these patients? We need to know the prognostic factors, which can be variable and multiple, depending upon the performance status of the patient, the stage, the age, the smoking history, which line of therapy, the absence of weight loss, any comorbidities, the absence of extrathoracic lesions, especially after the start of the third line therapy, the the treatment-free intervals, then the predictive factors, which would be the response to the first line therapy or the second line therapies, the treatment benefit, the treatment toxicities, the patient preferences, and the financial toxicities is something again very important when we're talking about treatment in our country. So next slide. Okay, so now this is broadly when we're talking about the management of advanced NSCLCs in the non-squamous histologies. These patients are treated with multi-agent chemotherapy, which is usually a platinum-based platinum doublet. Now, this can be combined with drugs like bevacizumab. Now, these patients after initial therapy are, if they have a response, are taken up for maintenance therapies, which could be depending upon the primary treatment that the patient has received. But eventually, the patient's progress, that is when the patient is taken up for the second-line therapy, for which nivolumab is a category 1 indication as per the NCCN. We have other drugs available also with us in the second line therapy, the ICIs and the chemotherapies, and the combination of various permutation combinations of the VEGF inhibitors along with chemotherapy, and so far and so forth. But these are mostly for the patients with good performance status. Patients with a poor performance status are basically taken up for best supportive care. Next slide. Okay, so now this is similarly when we're talking about the management of advanced squamous NSCLCs. Overall, patients with good performance status are taken up for initially with multi-agent chemotherapy, and then on progression taken up for a second-line chemotherapy, where again nivolumab is a category 1 as per the NCCN, and we have other combinations also. Docetaxel maintenance, I do not prefer docetaxel maintenance. It is kind of, I'll just, okay, move on. Next slide. So now coming to the data, we have now the checkmate 017 and the 057 in the 2 histologies. We have the updated 5-year outcomes, which we'll be talking today. So next slide. Yeah, so this is a checkmate 003. This was the phase 1 trial. This was nivolumab was given at 1 milligram, 3 milligram, and 10 milligram, and second line or more advanced NSCLCs. We saw that both the histologies patients did quite well, and the dosing again 3 milligram was fixed because of the 26% OS as compared to the 13% and 11% in the 1 milligram and the 10 milligram, and both the histologies had an overall 5-year overall survival somewhere about 15%. Now that was something very encouraging. So next slide. Okay, now this is the combined the checkmate 017 and the 057. The checkmate 017 was the squamous histologies, and 057 was the non-squamous histologies. Patients in the second line therapy after any first line therapies were taken up randomized 1:1 to receive either nivolumab at 3 milligram per kg 2 weekly, or docetaxel at 75 milligram per meter square 3 weekly dosing. The primary endpoint being the OS and PFS overall being the secondary endpoints. Treatment continued until progression or unacceptable toxicity. Next slide. So we have the overall survival Kaplan-Meier graphs. You can see the graphs beautifully separated apart, and the 5-year overall survival of 13.4% as compared to 2.6% with docetaxel. Now that's a dramatic difference. The median overall survival of 11.1 months as compared to 8.1 months, and the hazard ratio of 0.68. Next slide. So now talking about the patients who had a Pdl1 positivity of 1% or more, we can see again the Kaplan-Meier graphs beautifully getting separated apart, and even at 5 years, the overall survival of 18.3% versus 3.4% in the patients with a median overall survival of 13.4 months versus 8.5 months, and a hazard ratio of 0.61. So next slide. This is again something very important for poor people like us. We have patients, who have a Pdl1 less than 1%. So even in those set of patients, we've seen that there is an overall survival benefit. So we can see the 5-year overall survival of 8% versus 2%. in the nivolumab as compared to docetaxel, and the median overall survival of 9.7 months versus 7.8 months with a hazard ratio of 0.76. So next slide. Okay. So now this is that was the pooled analysis for both the trials. Now, if we see individually, we have the Checkmate 017, which was the squamous histologies, the 5-year overall survival of with nivolumab of 9.2 months as compared to 6 months with a hazard ratio of 0.62, and a 5-year survival rate of 12.3% versus 3.6%, which is almost equating to 4 times the benefit survival rate, higher survival rate. Next slide. So similarly, we can see the Checkmate 057 data, which is for the non-squamous histologies, and we can see the median overall survival with nivolumab of 12.2 months versus 9.5 months with a hazard ratio of 0.7 and a 5-year overall survival possibility of 14% versus 2.1%, approximately 7 times. So next slide. This is the forest plot. We can see all the subset of the patients are getting benefited, except for the patients with the age more than 75 years. But overall, most of the entire subgroup of patients are getting benefited and crossing the line of no effect. Next slide. So now these was the OS data. We also have the secondary endpoints, the PFS and the duration of response data. The PFS with nivolumab was a median PFS of 2.5 months versus 3.5 months with a hazard ratio of 0.79 and a 5-year progression-free survival of 8% versus 0% with docetaxel. Similarly, the duration of response of 19.9 months with nivolumab as compared to 5.6 months with docetaxel, and 5-year patients who are responding of 32% versus none with docetaxel. Next slide. So now this is again quite interesting. If we see the patients who had a partial or a complete response, in those set of patients, the median overall survival with nivolumab is not reached versus 16 months. And the median duration of response is 19.9 months versus 5.6 months with docetaxel. The 5-year survival rate of 53%. That means approximately, more than half of the patients are alive in the set of the patients who have had a response, be it a complete or a partial response, as compared to just 6% with docetaxel. The overall response rates with nivolumab were 19.7% versus 11.2% with docetaxel. Again, even the ORR, sometimes people, state that the ORR would be higher with the chemotherapy. So again, the ORRs are also 19.7%. Next slide. And this is again interesting. If we see the patients who have not progressed or who have responded after about 2 to 3 years. Now, those set of patients have, kind of behaved as if they've been cured of the disease. The patients who are progression free after 4 years, so 100% of those patients are alive. This is something very interesting. So after 2 years, this is 60%, and at 3 years, this is 93%. So next slide. Next slide, please. Okay, can you go one slide back? Yeah. So this is the baseline characteristics. You see the patients who survive for less than 1 year as compared to the patients who survive for more than 5 years. All the characteristics are similar except for the PS. The good PS patients in the patients who survived for less than 1 year was 17% in the nivolumab arm as compared to 40% in the 5-year survivors, and where in docetaxel it was 22% in the less than 1 year survivors and 56% in more than 5-year survivors. The next thing was the Pdl One Status, which was more than 1%, was 49% in the patients who survived less than 1 year, whereas it was 75% in the patients who had more than 5 years survival as compared to 57%. Next slide, please. So now if we talk about the patients who are the long-term survivors, what happened to those patients in the nivolumab arm? There were 50 long-term survivors. Out of these, 21 progressed, and 2 patients of these did not receive the subsequent therapies, whereas majority, the 19 patients, received subsequent therapies, of which mostly they received probably chemotherapy, other therapies, and 7 patients received immunotherapy even in the later lines of even after progression of nivolumab. And there were 21 patients who did not progress. Of these, 5 patients were off treatment. Now, the median duration of treatment in these patients was about 9 to 44 months. So after that, these patients have been off treatment and have not progressed. Now, this is again quite interesting. And whereas 16 of the patients are on treatment. So next slide. And coming to the safety profile nivolumab, I think we have all used this drug in huge number of patients. We've seen the drug is quite tolerable. We did not, usually do not get much toxicity. The side effect profile is by far it's a good drug to handle. The asthenia, the fatigue is something which is quite common. The diarrhea, the GI, the skin dermatological toxicities, the endocrine pulmonary hypersensitivity reactions are less. The grade 3, grade 4 side effects are quite less. Next slide. So to summarize, Opdita or nivolumab has delivered a good 5-year overall survival, even in the second line setting in advanced NSCLCs, 13.4% overall survival at 5 years versus 2.6% with the chemotherapy. It is the trial as the longest follow-up, and this is again very important. Even with that, long follow-up, we've seen these about 15% overall survival in the second line setting. So the patients who have not progressed at second or 2 or 3 years, and those are the set of the patients who are mostly alive and done beautifully. The 5-year at this is again interesting. This is what we saw in the survivors. So there were 10% of the survivors who were off study and they were off treatment and they have not progressed. They've received a few doses, maybe somewhere about 8 to 9 months was the minimum, to about 40 to 44 months of treatment, and then they have stopped the treatment, and even then these patients are not progressing. Again, we've seen such results in even in RCC with the nivolumab. Okay, and next is the that's it. Thank you.
Thank you, sir. Thank you, Nova Gupta, sir, for the brilliant presentation. And we move today for the last session. For this, I would like to invite Dr. Krupa Shankar, who is Director Consultant Medical Oncologist, Coimbatore, and he's going to talk on management of EGFR positive NSCLC. Over to you, sir.
Thank you. I'll just share my screen and we'll get started right away.
Yes.
Hi, Kripa. How are you?
Hi, sir. I'm good. Well, hope my slides are visible and I'm audible. So, a very good evening to everyone. And at the outset, before I begin, I'm going to take this opportunity to congratulate the organizers and also thank them for the opportunity. A special word of mention to Roxaman sir for putting together this wonderful academic event. So I know I have this onerous task of doing this panel discussion all by myself. So I've never tried doing that, but let me see how it goes. So as far as the incidence of EGFR mutation is concerned, we all know that it's around 20 to 30% globally, and it's more common in never smokers. And most of the commonest EGFR mutations usually happen between exon 18 to exon 21. And then the less common or uncommon mutations, as you would call it, actually happen in exon 18, which is the G719S, or the exon 20 S7681 mutation, and the other being exon 21 L861Q. And sometimes you can have complex or compound mutations or even co-mutations happening as well. So quickly, I know we've had a lot of discussion in the metastatic setting, so I'm just going to quickly brush through the data in the adjuvant setting for the use of EGFR inhibitors. This was the early data, the Chinese Thoracic Oncology Group, the adjuvant data, which was a phase 3 trial looking at patients, enrolling patients from China. And the randomization was again between Gefnib versus chemotherapy, and that's what made it interesting. The primary endpoint being DFS. Baseline characteristics were again pretty evenly matched in both the groups. And this was the overall survival. And let me again remind you that the primary endpoint of the study was DFS. This was not powered adequately enough to answer the question of whether it could show an improvement in overall survival. But having said that, you can see that the curves are almost hugging each other. But probably what I would say in clinical practices, would this be relevant? an absolute improvement in survival of close to 12 months, 75 versus 62 months. So probably, yes, I would take that with a pinch of salt, but still, let's get on to that, and I'll probably tell you why. And let's look at the 3-year and the 5-year updated disease-free survival rates. And you can see that there's an absolute improvement again of close to 11 months. However, this was statistically significant, and this was powered adequately to answer that question as well. And going by the post-hoc analysis, depending on the duration of adjuvant EGFR, first generation EGFR TKI, so patients who went on it for more than 1.5 years seem to benefit, whereas patients who went on it for less than 18 months did not seem to derive the same magnitude of benefit. And here the duration of entire total duration of gefitinib was for 2 years, as opposed to 4 cycles of platinum-based doublet. So let's look at the other study, very similar design. This was the IMPACT study, and this was Japanese data. So we all know that the LACE meta-analysis has clearly established cisplatin-based doublet as the treatment of choice as far as adjuvant chemotherapy is concerned. That has shown an improvement on 5-year survival of close to 5%. So let's look at how that happens, or how the EGFR conundrum actually fits in there. So here again, the randomization was between gefitinib for 2 years versus a platinum-based doublet, which was cisplatin versus vinorelbine for 4 cycles. Here also the primary endpoint being DFS and secondary endpoints being overall survival. And interestingly enough, looking at the rates of treatment completion, there was nothing much to choose from here, but the discontinuation rates surprisingly were higher with the first generation EGFR TKI, 40 versus 20%, almost double. But again, as you could see here, most of them was because of progression of the disease, relapse or second malignancies, close to 16%, and adverse events were only 12 versus 8%. And again, the DFS, the primary endpoint of the study, even though it did show an improvement of close to 11 months here as well, but this was not statistically significant. Look at the hazards and the p-value. This was not statistically significant. So again, I think this has got to do with the numbers. Again, less than 200, close to only 200 patients were enrolled on this study as well, and this was probably one of the reasons as to why this primary endpoint was not met, and probably it was not powered adequately. So I probably, I'm not sure if they can see a difference between both the studies, but probably this is just goes to show that statistical jugglery can actually make one trial look better than the other. So this is just a cross-trial comparison between these two studies. Look at it in terms of absolute improvement. I know these are only cross-trial comparisons, but still 11 months improvement in the DFS in both the studies. But one was a positive study and the other was a negative one, at least as far as the primary endpoint was concerned. And again, moving on to the subgroup analysis, well, clearly again, as you can see, gefitinib seemed to be doing better in most of those patients as opposed to a platinum-based doublet, and no improvement in overall survival. Again, like I said earlier, it was not powered adequately enough. And again, subgroup analysis also definitely did not show any magnitude of benefit with gefitinib. And the adverse events, nothing much to choose from, something that we've always known with EGFR TKIs, which is skin reactions, diarrhea, which are all class side effects. But I know this is something that always gets debated on. Suppose what if your patient cannot afford osimertinib in the adjuvant setting? Would you then put them on EGFR TKI or a first generation EGFR TKI? And are you actually letting them selectively develop brain metastasis? So, the way I would look at it is, first of all, the patient has got to live long enough to develop brain metastasis. So I think then comes the question of whether, we're letting them selectively develop brain metastasis. Because remember, when you're talking about survival, 5-year survival for somebody with even stage 1 non-small cell lung cancer, it's only to the tune of around 50 to 55%. And that's Western data in a developed country. So that is just to put things in perspective. So you're not wrong in actually offering an adjuvant gefitinib as well, or even a first generation TKI in somebody who cannot afford osimertinib, or in somebody who's not fit for chemotherapy at that point in time as an alternative to chemotherapy, adjuvant chemotherapy. And the subsequent treatment as well, this was how it was. I mean, patients who had the chemotherapy also subsequently went on and had TKIs. So that's how it, and osimertinib, we all know in the second line is approved only for patients who have a T790M mutation. So again, the IMPACT study, to summarize, again, was a negative study. So we have one positive study which met its primary endpoint of DFS, another study, even though the magnitude of benefit was similar, statistically not significant. Like I said, a lot of statistical jugglery was on. So again, I think the key points here, and I try addressing all these points myself. What percentage of patients usually present? It's less than 10%, 6 to 8% only, and that's based on the TMH data as well. I don't remember the last time when I saw somebody presenting with operable lung cancer, because remember, resectability and operability are two different things. Resectability basically means that anatomical or radiological resectability. But when it comes to operability, there are a lot of other factors that go into it as well, like the patient's age, performance status, comorbid conditions, all of them. So I think that's why you call it operable lung cancer, and then that's less than 10%, only around 6 to 8%. What proportion will be EGFR mutant in the adjuvant setting or with localized lung cancer? I'll show you the data as well as we move along, but it's only to the tune of around 10%. Historical control showed it to be around 20%, but now we have data to show that it's only around 10%. Role of predictive radiogenomics, again, there are a lot of studies looking at that as well, meaning just can you predict someone to likelihood of having an EGFR mutation just based on the radiological imaging or the findings. Yes, there are certain points, like for example, the ground glass opacity, perihilar distribution of the lesions. So, there are a few pointers, but again, that's a work in progress. You cannot rely on that completely. What percentage of patients go on to receive adjuvant chemotherapy? And that I'll address it in my next slide as well. Because if you look at the ADAURA data, which has now become standard of care, adjuvant osimertinib is now an approved option. Even in that study, only around 50% went on to receive adjuvant chemotherapy, and the remaining 50 went on to receive osimertinib straight away. So, is it practice changing? I would say yes. At least for those patients who can't afford osimertinib, yes. And this is the data that I was alluding to, the prevalence of EGFR mutation testing and the incidence in early stage or in up to stage 3. So, like I said, only around 10%, which was about half of the anticipated 20%, which is what was looked at as historical controls. So then again, I think the key question about ideal duration of treatment, do you just do 2 years, stop at 2 years, or do you continue until progression? Again, that's an unanswered question because, the ADAURA study looked at 3 years, whereas the other two studies, which I just presented now, the adjuvant and the impact, only looked at 2 years, and that was a direct comparison with chemotherapy. Overall survival data agreed, yes, these two studies, the first generation EGFR TKIs, have not shown any overall survival data, but remember, they were not powered adequately also to show that. So remember the difference in numbers. These two studies had only 200 patients. ADAURA had 600 patients, which is why they were probably able to show an improvement in survival. And exploratory post-hoc analysis, that's only an exploratory subgroup analysis, but still, if you had patients going on more than 18 months of GEFNIB or a first-generation EGFR TKI, then the magnitude of benefit was preserved. Not going to get into the details too much of these ADAURA study as well, but this is the study that led to the approval of osimertinib in the adjuvant setting. The randomization was between osimertinib versus placebo, and again, patients could have adjuvant chemotherapy as well. And I'll get to that a little bit later on. Only around 50% had received, 54 to be exact, actually received adjuvant chemotherapy followed by osimertinib. But again, the key thing is that all patients with stage 3 disease went on to receive adjuvant chemo and then osimertinib. Stage 2, a lot of them went on to receive straight away osimertinib without adjuvant chemotherapy. So again, they were pretty evenly balanced, and like I said, prior adjuvant chemotherapy, 50%, 55% to be exact, in both the osimertinib and the placebo arm. So the primary endpoint, well, this was definitely met, and this was stunning. The hazard ratio, I don't remember the last time I ever saw a hazard ratio of 0.17. That translates to about 83% relative risk reduction. So that's fantastic news. And again, in the overall population as well, including stage 1B to 3A, well, again, the magnitude of benefit was preserved. Even though in practice, probably, I wouldn't want to do it for stage 1B. I'd probably want to reserve it only for stage 2 and 3. Because look at the magnitude of benefit. Stage 1B, you can see that the curves are almost hugging each other, but stage 2 and 3, the curves are absolutely split wide apart. So the quantum of benefit is definitely much higher in patients stage 2 and 3A. And again, the overall survival data is immature, which is why we've not yet seen the curve starting to separate. But probably with due course of time, we'll be able to show an overall survival benefit as well. So to me, definitely a blockbuster. So again, this is something that I really wanted to highlight. Like I said, close to around 55% went on to receive adjuvant chemotherapy in both the arms. And you can see that the magnitude of benefit was higher in patients who had actually received adjuvant chemo and followed it up then with 3 years of osimertinib, as opposed to patients who went away straight onto osimertinib without adjuvant chemotherapy. So, and again, stunning. Look at the forest plot again. Across all subgroups, osimertinib scored over placebo. And again, safety data, nothing much to write home about. Again, pretty similar to what we've seen with the earlier osimertinib data. So definitely practice changing. Adjuvant or maintenance alone, I think we'll have to follow it up. Adjuvant chemo followed by maintenance osimertinib for 3 years is the current standard. Ideal duration of treatment, yeah, the trial says 3 years. Would you want to continue it until progression? That's your guess is as good as mine. Overall survival data, again, we'll have to wait for the data to be mature. And even for stage 1B, not so. Probably from stage 2 onwards, definitely yes. And the Alchemist is interesting because this is the Alchemist data, which is like horses for courses. So meaning if you have somebody with an EGFR mutation or an ALK mutation, then you put them on EGFR inhibitors or ALK inhibitors in the adjuvant setting. And if they're all negative, then you put them on maintenance immunotherapy for 2 years. So that's probably, how things are going to evolve in the future, and that's how it is going to look in the future. So what about the LAURA data? This is something which we're all keenly anticipating as well. We know durvalumab now is the current standard of care for somebody with unresectable stage 3 lung cancer post concurrent chemoradiation. But what about patients who have an EGFR mutation? Because the specific study did not include a lot of patients who had EGFR mutation positive, only around 10%. So again, I think that's a key point, because we've always spoken that in patients who have a driver mutation, what about the predictive ability of immune checkpoint inhibitors? So I think that's where this LAURA study is probably looking at answering that question. So post concurrent chemoradiation, osimertinib versus placebo, keenly anticipated results. So we'll have to wait for that. And again, what are the latest EGFR, third generation EGFR inhibitors? Because until now, we only had osimertinib, and osimertinib was unchallenged. So now we have a lot of contenders to the throne, and one of them being aumolertinib, which is again one of those Chinese molecules, if you really aren't to that data. So this was the phase 3 data, the INEOS data, which was actually pretty impressive. So look at the primary endpoint, which is progression-free survival, 19 versus 10 months, which is more in tune of what we've seen with the FLAURA data as well. And this is in patients with metastatic stage 4 in the first line setting. So look at it again in patients even with brain metastasis, always, as we've seen with osimertinib, aumolertinib also has shown a similar magnitude of benefit. And safety profile is very consistent with what we've seen with the earlier EGFR TKIs, only the class side effects. So this was a phase 3 trial, albeit, you could always say this is unshiny data, but I guess this is something that will really make an impact in the future going forward as well. Will be a real contender to osimertinib. And is that the only third generation EGFR TKI? No, we have another one as well, which is called formonertinib. And again, this was also looked at in the furlong study. This was another phase 3 data looking at comparing it versus geftinib. And again, you can see that the median PFS was 21 versus 11 months. And the safety profile is consistent with what we'd seen with the earlier third generation EGFR TKIs. So again, we have two contenders to the throne, aumolertinib and formonertinib. So watch out for that space. It's a constantly evolving one. What about EGFR exon 20 insertions? I know these are mutations that cannot be targeted with your conventional EGFR TKIs, and the current standard remains in the first line a platinum-based doublet. And on progression, now we have two FDA-approved options. One is amivantamab, which is an anti-EGFR MET bispecific antibody, and then the completely oral EGFR TKI, which is mobocertinib. These are the two drugs that are currently FDA-approved for EGFR exon 20 insertions post-progression on a platinum-based doublet. And again, poziotinib, the Zenith data was promising, but not yet approved. Pyrotinib, yes, again, data looks promising, but again, it's not yet currently approved. And apart from this, I can also add yet another third generation EGFR TKI is lazertinib. We have ongoing trials looking at a combination of amivantamab plus lazertinib in patients who progress on osimertinib. So that again is very interesting data, looking out for that. And then again, before I conclude, I think we have patritumab deruxtecan as well, which is probably the only antibody drug conjugate which can target HER3. Again, that works in HER2 exon 20 insertions as well, and that's being looked at in non-small cell lung cancer. So before I conclude, I'd also going to touch on the oligometastatic space. So what about patients with an oligometastatic EGFR mutant non-small cell lung cancer? Is there a role for local therapy in those patients? And this was interesting. This was a phase 3 trial, again, Chinese data, EGFR TKI with SBRT versus EGFR TKIs only, primary endpoint being PFS. And again, the baseline characteristics were pretty evenly matched. Icotinib was used, but remember that's because that's approved in China, but it's not FDA or DCGI or EMA approved. So that's how it's already been. Probably the same thing shouldn't happen to aumolertinib and formonertinib as well. I hope we have access to those third generation EGFR TKIs. This was the primary endpoint of PFS. Well, again, as you can see, local therapy did seem to improve on it. However, let me get to that a little bit later on, as far as was it statistically significant enough for us to actually change our practice. And safety profile consistent with what we'd seen earlier. So again, is this practice changing? Probably yes, but then would you do it for everybody? No, I think, we really have to look at patient selection criteria, because there's no fixed about definition of oligometastatic disease. because you'll have to look at defining the number of lesions, the site of lesions, and size of the lesions as well. So, I think that's how it is, up to 5 lesions and up to, not more than 3 centimeters and not more than 3 lesions in a particular organ. So I think that's one way of defining oligometastatic disease. And what about choice of TKI? Because remember, this trial looked at only using a first generation TKI. So would you have the same benefit if you gave a third generation TKI and compared it with a third generation TKI like osimertinib? Again, that is an unanswered question. And timing of radiotherapy, I think we'd probably look, given that it's stage 4 disease oligometastatic, we would probably look at seeing how well the patient responds to a particular line of therapy before we actually go ahead and give them local therapy, local consolidative therapy. And this study actually excluded patients with brain metastasis. And that's a big criticism because we know patients with EGFR positive disease have a higher incidence of having brain metastasis, up to 15% at baseline and 30% at the time of progression as well. And what about the role of surgery as well? Is it only radiotherapy or could you do a surgery if somebody's got an isolated CNS met? So this is a list of all, and this is only cross-trial comparisons. We have a host of studies looking at the role of local therapy in oligometastatic disease, but this was the first one, which was phase 3, and also looking at particularly EGFR mutant non-small cell lung cancer, has shown an improvement in PFS and overall survival at a pre-specified interim analysis. But however, we'll have to, there are a lot of criticisms. I'll talk about it in my coming slide. So again, there was an imbalance between the EGFR mutations and TKIs. Again, exon 20 insertion were also included. And again, they looked at patients, they excluded patients with brain metastasis. So like I said earlier, the location of mets matter and how many sites could you end up radiating. So I think these are all key differences. So, and what about the role of other local therapy like surgery? SBRT probably less invasive, quality of life better. But again, I think the standard arm needs to be much better than a first generation EGFR TKI. Should have been a third generation EGFR TKI like osimertinib. So with that, I'll conclude and say thank you all for your patient listening and hand it over back to the organizers.
Thank you, sir. Thank you so much. And now I would like to invite Dr. Suman Gupta, sir, for the concluding remarks.
Thank you, everyone. And Kripa, your talks have been marvelous recently. So you have become an excellent teacher. I think what started long back has been a tremendous journey. Thank you, everyone. Thank you, the team, for such a nice conference and all the faculty. And I think it is time to wind up. It's been very late. I thank you, everyone, all the sponsors and Healthy Blossom event management team. Thank you, everyone, for a lovely evening. Good night,
Sir.
everyone.
Good night, sir. Good night, everyone. Thank you,
night, sir.
everyone.